So today we're going to be talking about quality asthma control. My name is Elizabeth Locker, and I made this presentation and will be doing this presentation. So first off, I just want to say I'm sorry if I appear nasally or congested. I am a little bit congested right now. I do have allergies, so yes. And then also my dog is sleeping next to me, so you might hear him snoring. But this second slide, we're going to be talking about key clinical action steps. So really just some key symptoms that you often see in asthma, just to look out for. So that could be wheezing, coughing, tightness in chest, shortness of breath. Sometimes people don't get like all of these symptoms at once. They'll more so have like a little feeling of tightness in their chest, and then they're like, okay, and then a little bit of wheezing on like a routine basis, and then they don't realize that it's gone to the point now where now they're short of breath, and then they have the exacerbation, which is, a lot of symptoms. So this can present differently just depending on the patient. A lot of times our immune systems are weakest in the evenings, so you're going to see more of the symptoms persist and present in the evening. Also exercising. Exercise-induced asthma is a real thing, and it's one of the more common types of asthma. There's even athletes who have exercise-induced asthma. But another way is when sick with the flu. So the patient may feel fine, have a history of asthma, they had asthma when they were a kid, they kind of thought that they grew out of it, and then they get really sick with like influenza A or something, and that kind of causes, their body to be in stress, right? And so it brings out those symptoms. And then, like I just mentioned, allergy season. Allergy season is a big thing. Where I'm from in Florida, it's really heavily pollinated. Usually this time of year, my eyes are like really swollen, and I have trouble breathing, and it's like an extreme, allergy symptom. Whereas here in Tennessee, it's not nearly as bad because the pollen is not quite so thick. It doesn't lay on cars, and it's not quite as prevalent as it is in Florida. And then when we're looking at patients that are 5 years or older, we want to look at incidence spirometry because it just kind of helps measure lung function, just to make sure that their lung growth hasn't been diminished due to their asthma. So next we're going to be discussing some special circumstances when it comes to asthma. The one that I feel like most people hear about is exercise-induced asthma. This is something that when initially talked about, it might not seem that bad. Okay, like you feel short of breath, you feel a little bit wheezy, right? But when we're, talking about an asthma exacerbation due to exercise, when you see someone bronchospasming, think of kind of like that cat that I described in the last video. You don't really fully realize what that looks like and how scary that can be until you witness it. And then you're like, oh wow, this is bad. This person needs help. Educating the patient is kind of a key thing, like about initiating or starting or taking a short-acting bronchodilator therapy beforehand to, minimize their symptoms. We still want to make sure that we're emphasizing the importance of physical exercise and to help maintain lung functions and the mobility of the airway. So exercise is still important, which a lot of times patients struggle with, not wanting to exercise when they have exercise-induced asthma, because imagine doing something and that causing you physical pain, shortness of breath, wheezing, bronchospasms. Like, I could understand not wanting to exercise just because you don't want to risk feeling that feeling. But still emphasizing how important that is, especially with weight management, because if you have exercise-induced asthma and then you were to gain a bunch of weight, that excess weight on your body also, increases inflammation in your lungs, and your bronchial airways, and so it makes it a lot harder for you to breathe. And then people sometimes develop other things like, sleep apnea and stuff because of that. So just emphasizing that, and then possibly adding in a long-acting bronchodilator to cut down on the severity and the frequency of their exacerbations. An asthma exacerbation in general can often be a good indicator that the patient's control treatment plan is not really effective or helping them at this time. So if someone's coming in 3, 4, 5, 6 times a year, with an asthma exacerbation, it might mean that their maintenance drugs really aren't working. I was at Centennial on Tuesday, and there was a patient that was going to be discharging soon for asthma, and she came in with an asthma exacerbation, and she mentioned that she really hates taking the inhaler, and so the respiratory therapist I was with, offered her the nebulizer and said, hey, if you really like using the nebulizer, you can use the nebulizer at home. We would rather you use the treatment and not have an exacerbation versus you having the inhaler and then not using it. So he reached out to the doctor, and the doctor figured out, I forget exactly what he said, but they figured out a way that she could get it after she discharged. He referred her to a specific pulmonologist that could help her with that. So that's definitely one type of asthma that is good to know. And then also for pregnant women, a couple of my close friends just had babies, and their bodies really went through a lot of changes being pregnant. Kind of like with gestational diabetes, how someone might not have diabetes, or maybe they do and they don't, and it's very, very well managed. And then when they get pregnant, having this uncontrolled, diabetes, it's a lot in the same way like asthma. Maybe the person has really mild asthma or asthma when they were a kid, and then they get pregnant and it really exacerbates it. So one way we can kind of look at this and manage it is just by checking in with them during their prenatal appointments, to make sure that they're not having a lot of shortness of breath, tightness in their chest, wheezing, bronchospasms, all of these things. And then how we can better, treat that asthma with the safety of the mother, and the baby also being in mind. Because that can also affect the fetus, because anytime we think about inflammation in the body, it affects everything, right? For some, moms, this could, or pregnant women, this could look like, implementing an inhaled corticosteroid that, really helps reduce inflammation, that maybe they haven't been on before, but just for, long-term control management. And then also reminding them not to smoke, not to vape. Sadly, I've seen already at clinical, numerous times where a pregnant person or pregnant woman will come in and like their family member, whoever, tells us that like, yeah, they do still vape, or like, yeah, they just stopped smoking when they found out that they were pregnant, but they've already been pregnant for the last 4 or 5 months. So these are just all important things to kind of keep in mind when we're talking about asthma. So I'm just going to quickly run through kind of managing asthma exacerbations and what that might look like from different perspectives or avenues. So asthma control, ultimately the goal is to prevent chronic symptoms and for the patient to not have to rely heavily on their rescue inhaler while still maintaining their activities of daily living. At the same time, negating symptoms associated with therapies and minimizing adverse lung functioning. A lot of this is depending on and assessing, monitoring patients' use of the medication, how to properly use it, as well as encouraging a written action plan. So a lot of times this just looks like emphasizing the importance of a written action plan, encouraging the patient to like journal their symptoms or, write them down or put them in their phone's note app, whatever. And then also just monitoring the effectiveness of the medication and whether or not it needs to be adjusted or maybe, lessened if they're not really using it to the severity level that they originally were. Home care is another big one, so educating the patient on, how their environment can really affect their asthma. Home care is a pretty independent space, so as a respiratory therapist, when you're going into it, it's, really encouraging the patient that they're the one that's in control, right? If they don't clean their, let's say they have, a nebulizer or a CPAP, if they don't clean that, then no one is cleaning it essentially, and it's just building up bacteria, So like emphasizing that they are in control, and then also like, the importance of having a written action plan in place for when they're not doing too good. And then looking at whether, their short-acting bronchodilator needs to be increased or if something needs to be added, like inhaled corticosteroid, or if something should just be changed, maybe the medication that they're on is just not really helping them and they need, more emphasis on like an anticholinergic, to help like dry up maybe excess secretions because they're having an environmental reaction where mucus production is increased. So that's pretty much it. And then lastly, hospitalization. So this could also be like ER visits, or maybe someone coming into the hospital like on the, pulmonary like outpatient end, or just looking at assessing lung function and medications. This could really be anything like bedside spirometry and sedum spirometry. I put PFTs in here just because, sometimes someone will have like, I had a patient the other day in clinical that grew up with asthma and had really bad asthma exacerbations. And then he was also a long-term smoker. So they wanted to look at to see like if maybe he also has COPD and maybe if that's playing into it or if it's just emphysema, and if so, like what's the severity on that, and then just looking, just having a doctor, assess a patient with a full patient assessment, and what the signs and the symptoms are, And then just medication, you know, supplemental oxygen is one to help improve that hypoxemia. Implementing duoneb, so that, you know, albuterol and ipratropium bromide combination. You know, Pulmicort, it's another big one that's we often see in the hospital. And then sometimes like just increasing the frequency if when they first come in, they're just getting it PRN, and then they may need it, you know, Q4 or Q6. So yeah, thank you so much for watching. See you in the next video.